Okay, I'll just wait for participants to join in and then I can introduce you, Dr. Meenakshi.
Okay.
Okay, I think we can go ahead now. So hello and welcome to the Q&A session on cutaneous T-cell lymphoma. My name is Nella and I'm the Executive Assistant at Lymphoma Canada. I will be the facilitator for this session today. I'm pleased to welcome here Dr. Meenakshi Taparia, who will answer your questions from the breakout sessions on cutaneous T-cell lymphoma, also known as CTCL. As a reminder to our audience members, please type your questions into the Q&A chat box in the middle of the black toolbar at the bottom of your screen. We will try to answer as many questions as possible. Okay, I'll just wait a second for some questions. Okay, we have a question, Dr. Meenakshi. So she says, thank you for the great presentation, Dr. Taparia. What is your experience with stem cell transplant for CTCL?
So thank you for the question. It's a great question. As you probably also know, that it's not very well known about the effects of the transplant in patients with CTCL. There is very small case series that have been published so far. So it's not like a randomized trial or anything that we have. And the effectivity or the response rate, overall response rate, is said to be anywhere between 30 to 40%, and the like 5-year progression survival of the disease is also close to that range. So again, not, as I said, not a lot of data. We have sent a few patients for transplant who have been refractory to a lot of treatments that we had available. And now that we have newer treatments available, we probably will be sending less people, but I have had maybe about 4 patients referred and had good responses in about 2 of them, and the 2 of them had relapse of their diseases.
Thank you, doctor. So the next question is, are there any emerging therapies or clinical trials for CTCL that patients should be aware of?
So no clinical trials that are available in Canada at this time that we are aware of. There may be some other clinical trials looking at PD-L1 inhibitors that is being looked at, which is a checkpoint inhibitors that I'm kind of currently aware of. But otherwise, at any of our centers, we don't have any clinical trials that are open to us.
Okay, thank you. So one of the common side effects of brentuximab is peripheral neuropathy. How is this managed in the clinic?
So brentuximab is a quite effective drug, but we also know that it is known to cause peripheral neuropathy. It can cause anywhere from grade 1 to grade 4 neuropathy. It can be sensory or sensory motor. We definitely tell our patients before they start the chemotherapy to watch for any tingling or numbness in their hands or feet. If they start noticing any problems with motor activities like holding a cup or holding a pen and writing, and if they're finding it difficult, that means it's kind of progressing, or buttoning their shirt. So small things that are practical day-to-day things, we ask them to watch for it. We see patients prior to every round of chemotherapy and ask them the same questions so that we know if there is any progression. If it is just mild grade 1, we will continue with the same dose. But if it progresses, then we will definitely, depending on how severe it is, we might have to completely hold the chemotherapy. But if it is just mild progression, we might dose reduce the chemotherapy. So, go to maybe 1.2 milligrams per meter squared instead of the 1.8. And if it is quite severe, we might go to half the dose in the patients. And sometimes it's just so severe that we have to completely hold the therapy.
Okay, thank you, Dr. Taparia.
I also sometimes refer these patients to neurology clinic to document it and get them to have some studies for the nerve conduction stuff to make sure that we are dealing with that and nothing else.
That's great, thank you. The next question is, what are the long-term consequences of radiation therapy for patients with mycosis fungoides?
So typically radiation in mycosis fungoides is localized to few lesions, and therefore it's not a lot of long-term radiation. We might see some hair loss in the area where they got it. Immediate side effects are erythema, but hair loss, it again depends on the area. So if you have it on the salivary gland area, there may be some dryness, but over a period of time, you might notice that. Obviously, eye shielding and all those things are done, but sometimes I've seen cataracts because of the long-term side effects from radiation. Depends on the total dose that they have had as well. So those are some of the things that we see. Some increase in maybe cancers as well, depending again on its dose induced. So
I just also want to say, if the new members that have joined in, you can type in your questions in the webinar chat box at the bottom of your screen. Okay, I'll just move on to the next question. You mentioned that long-term effects of phototherapy included skin cancers and cataracts. After treatment, should patients be screening for skin cancer as a preventive measure?
So we don't typically ask them to screen, but because they are typically followed by dermatology clinics, we do tell them to, if they notice any new lesions or a lesion that is growing or something, to make sure that they speak to the dermatologist or to ourselves. And if we see it's suspicious, then we can definitely have it excised and find out what it is. So, but there's no screening protocol as in how often they need to be seen. But as these patients are typically seen in the multidisciplinary clinic, they are already seen by dermatologists, so it doesn't necessarily need regular screening. And the second question is about cataracts. Usually when they get the PUVA, there is a lot of shielding of the eye and everything, so in the genitalia area. So typically it should not cause it, but they start noticing any changes to their vision, then they definitely should be made aware that there is some early cataract formation, so they should have it checked, but they don't require regular screening.
Okay, thank you for that. Next question is, are there specific lifestyle changes or supportive measures that can help manage symptoms of CTCL during treatment?
I don't see any necessarily any lifestyle changes, but yes, if there is, if the patients have known diabetes or other changes that makes them more prone to infections, definitely would suggest to have their sugars under control. It also, diabetes itself can cause neuropathy, so a better control of diabetes would be helpful because they may end up getting some drugs like brentuximab, which might cause neuropathy. So overall healthy lifestyle, but no particular changes to their diet as such or other things, and to watch for any kind of infections because that flares up the disease. So definitely that would have to be looked after, make sure that there's no super added infection on any of the skin lesions.
Okay. So we have one question coming in the chat. The question is, would you try mogamulizumab in early stage mycosis fungoides, or is it reserved only for late stage patients only?
It is not, but in Canada, it is approved if we have failed one systemic therapy for patients with both mycosis fungoides as well as the Sézary syndrome patients. Now, if by early stage, they mean early stage 1A, you definitely don't require that kind of treatment. But if it is, of course, like stage 1B or 2A, where they have extensive plaques and folliculotropic MF, and we have tried different treatments and it's not working, then we could certainly try that treatment. It would necessitate that we have used a systemic therapy before we can get this drug in Canada.
Okay, thank you. You were mentioning, this is in relation to the previous question about lifestyle changes. So are there any dietary recommendations or restrictions that may benefit CTCL patients during treatment?
None that we are aware of. There's no direct correlation with the diet.
Okay. What are the potential side effects associated with extracorporeal photopheresis for treating CTCL?
No major side effects as such, because this is outside of the body system that they're exposed to the psoralen, so they're not taking the tablets and the UV radiation. But the major problem would be getting an IV site in these patients with lots of skin lesions, so that can be difficult. Some amount of blood loss in the system when they're undergoing extracorporeal photopheresis, so they can become anemic. But other than that, and then line-associated thrombosis that can be seen, or infection at the site where they put the IVs. Other than that, no major side effects from extracorporeal photopheresis.
Thank you. The next question, how does age influence treatment options and outcomes for patients with CTCL?
Mostly, I do not think that age would have a big impact in the patients. The newer drug, the mogamulizumab, has also been tried in older people, and they have shown that the side effects are not as much, even in older people or people who have other comorbidities. It has been effective and not too many side effects. The only situation where age would be a factor would be for drugs like brentuximab, where if they have metabolic syndrome or pre-existing diabetes, which is for a long time, and they already have some neuropathy, that might cause an impact on using agents such as brentuximab. But otherwise, age is not a restricting factor for most of the treatments that we have.
Okay, that's good. The next question, what advancements are being made in understanding the genetic or molecular basis of CTCL?
So as far as I understand, and I'm not a research person at all, very clinical, but I know that there is a lot of focus on epigenetics and tumor microenvironment that has been going on to look at the different genetic mutations that the patients seem to have with these disease. And so there's things like JAK-STAT signaling pathway, where they have seen a lot of activation of these pathways, and so there are drugs that can be directed towards this JAK pathway to see if those would be effective in the future.
Okay. And how often should patients with CTCL have follow-up appointments, and what should they expect during these visits?
So again, the answer to this would be depends on the patient and the stage of the disease, typically. So in patients with very early stage disease who have good responses to these topical treatments like steroid ointments or other ointments, they do not require very frequent treatment follow-ups. They might require every 3 months to 6 months. Patients who have aggressive disease or more so later stage disease where they are on active chemotherapy, we frequently follow them on a monthly basis or more often depending on their chemotherapy cycle. And we see them prior to each chemo cycle before, and once their chemo is done, we might see them every 2 to 3 months. So again, it depends on the stage of the disease. So it could vary from anywhere between 6 months to a yearly appointment to as frequent as a monthly appointment.
Okay. Next question, what are the signs that indicate a need for a change in treatment strategy for CTCL?
So some of the signs would be that we've tried some of the typical topical therapy or skin-directed therapy, as we say, with the light therapy or ECP or, whichever ones we are trying, and we see newer lesions that are appearing, or there are more lesions that are appearing, or there is significant itching or more body surface area involvement. Clearly, the disease is not improving with what we are doing, and therefore we need some change in the strategy. We might need repeat biopsies if we notice some new lesions which appear like tumor, to make sure that there is no transformation of the disease to CD30 positive large cell transformation or others. And so we might need to biopsy those lesions again to make sure that we are on the right path. And if not, then we may need to change the treatment strategy depending on how the lesions are progressing.
Are there any new therapies in the pipeline for CTCL that you are particularly excited about?
We just have approval with the mogamulizumab, which is a very exciting new treatment that we now have available in Canada. It's only been about a couple of months that we got the approval through Health Canada and in different provinces. So I'm very excited and have had an opportunity to use that drug now on a number of patients with good responses. In the pipeline would be the JAK inhibitors. Maybe there might be responses to that, topical JAK inhibitors, and then the other drugs would be the PD-1 or the checkpoint inhibitors. That would be something more that we could be looking into future.
Yeah, that's great. How can advocacy efforts improve resources and awareness for CTCL in Canada?
Can I ask you to repeat the question, please?
How can advocacy efforts improve resources and awareness for CTCL in Canada?
I think it would be really helpful in terms of trying to get resources, such as a lot of centers do not have, particularly which are not more in the rural areas, we do not have access to treatments such as light therapy. We also, in our city itself, we do not have access to ECP, and patients have to drive to Calgary to get these treatments, which is every 2 weeks. Treatments such as TSEBT, we only have, I think, 3 or 4 centers in Canada, which we have it available. So I think advocacy for patients with CTCL would be really helpful in trying to get these resources for the patients where they are already suffering and significant itching and other symptoms. And if they have to travel and the cost and everything becomes too much for the patients.
That's correct. Thank you. Okay. Just wait for a couple of minutes if we have any questions. Okay, here we have another question coming. Are there any kind of biomarkers identified to select treatments for certain CTCL patients? Treatments that some patients should avoid or definitely be on?
Currently, we don't have any biomarkers that we know of that are used to kind of select or to know that these patients would need treatment. We know that in a ProCLIPI study that they had found patients with plaque stage disease or extensive disease are the ones, but there were no good biomarkers available. Now, the CD30 is one of the markers that we definitely used in patients where they have significant positivity for CD30. Brentuximab would be a drug that could be used. So that's the only available biomarker at this time that we have, that we know that can direct treatment to those. In the future, if we know that if we have any research on the JAK inhibitors, that might be something that we could be using if they find some mutations in the JAK-STAT pathways.
Okay. Yeah, we'll just wait for a couple of more minutes if there's any more questions. And
thank you.
We have some thing around 10 minutes more. Yes. If there are any questions to our audience members, you can type in the chat box or the webinar chat box at the bottom of your screen. So we have the same one of the members, audience members. They say thank you, and it's just to follow up on the previous question regarding anti-CD30BV. The question is, can anti-CD30BV can be used only for Sézary patients or only for MF?
No, it can be used for Sézary patients, and we have used it successfully in these patients as well. Sometimes it's difficult to get if we don't have like positivity in CD30 of more than 5%, depending on the province that you are in, but it has shown effectivity in Sézary patients as well.
Okay, I hope that answered your question, and they say thank you. Yes. We'll just wait for another a couple of minutes and then we can conclude the session. Yeah. So we have another question come in the chat box. What has been your experience with clomiphene gel, and how long do patients need to stay on therapy?
Unfortunately, this is not covered in our province, and so I do not have any experience with using this. I only know the data that it is good for limited stage disease, and most patients have to be on it for about 6 months or a little longer, and then they can stop and restart if they notice lesions. But because of the cost, it has not been approved in our province.
Okay. Yeah, just wait for a minute more. Yeah, I don't see any more questions, Dr. Taparia. Okay, so to conclude this Q&A session, I would like to thank you, Dr. Meenakshi Taparia, for taking this time to participate in today's conference sessions. We hope those watching today learned something new about their loved one's lymphoma subtype. Please tune in to the next session titled Symptoms and Side Effects Management for Lymphoma Patients. Thank you. And yes, thank you so much.
Thank you so much for having me here. And I hope that we get some more available treatments for our patients in the future.
Yes, I hope so too. Thank you so much. Yes.